Welcome everyone who has joined us. And this is our first Tuesday educational series that we're starting here at Centera Star Health Center. And we are a free wellness center focused on chronic disease prevention and management. And we focus on diabetes, heart disease, stroke, obesity. And our goal is to promote healthy communities. And we're working with the community as well. And we're open Monday through Thursday here in the Jefferson School downtown for anyone that doesn't know, and all of our services are free. And I am the RN. My name is Sator Dillard, and I'm here on duty Monday through Thursdays. If ever, if you want to call and schedule an appointment, my number is 434-984-4640. And our main office number is 984-6220, just for information for our guests attendees tonight. So thank you all for tuning in, and we're very happy to have Dr. Tiffani Dennis with us. Dr. Dennis was born and raised in the Midwest. After graduating cum laude with bachelor's degree in biology from the University of Kansas, she attended medical school at Creighton University. Dr. Dennis completed a residency in internal medicine at Virginia Commonwealth University in 2007. She has been practicing outpatient internal medicine as a primary care physician since then. Upon moving to Charlottesville with her family in 2013, she joined Centera Martha Jefferson Internal Medicine, and her focus as a primary care provider has always been promoting wellness and preventing disease when possible. So thank you, Dr. Dennis, for being here tonight, and I'm going to turn it over to you.
Thank you, Sator, and welcome everyone. Thank you again for inviting me into your group, and hopefully we'll have more people join us shortly. But I like the size because I hope that we can have a discussion, and please feel free, like wave your hand if you want to interrupt me. If you have questions, I understand you can unmute yourself. If you don't feel comfortable just discussing out loud, you can enter a question into the chat, and maybe Sator can help me monitor that. So if a question comes up, we can answer it along. I think I was given a very ambitious topic of chronic disease management, so I wasn't quite sure where to go with this. So I hope that you all can help me and guide me if you have specific, detailed questions, or you want to delve in depth a little bit more on a specific topic or a specific disease. So I'm kind of going to give a broad approach, like my philosophy of how we can and should think about chronic disease management. And then hopefully we can have kind of a discussion and question and answers about that afterward. So as Sator said, I practice primary care, internal medicine at Martha Jefferson, which is even more challenging in the last year than it has been. But, thinking about how we have to manage chronic disease has never been far away from my mind. And so this is definitely an appropriate topic for today too. When I think about chronic disease, I want to make sure we're all on the same page. Chronic diseases are things that we all think about, even if we don't know it. Most of us will have a family member, a friend, or ourselves who have a chronic disease, like diabetes or hypertension, some form of heart disease or asthma, chronic lung diseases. They touch all of us at some point in our lives. And the thing is that we have medicine, we have advances in science and technology that allow us to live with these chronic diseases in a way that, say a century ago, we weren't. People would die much earlier in the course of these diseases. So we do really have to think about, how do you live with this disease now, much more than previously. It's a little bit more of a burden. It's a burden on us as individuals, and it's a burden on the healthcare system to think about how to best live with chronic diseases. So we do have tools. That's the good news. And when I think about it, I also think that the goal of managing these things, and the goal in general that I have personally and with my patients, I hope, is to kind of live your best life right? We can't know, and we can't guarantee the number of days that we'll have, but I think our goal should be the quality of the days, having our best days as much as we can. And I have patients that come in and say to me, well, I don't want to know, or no, I'm not going to worry about that, or I'm not going to do that test, or I'm not going to look for that, issue, because I'm going to die someday, right? We're all going to die something. And that is very true. And I can't argue with that. We are all going to die of something, but that doesn't mean we have to suffer before we die. That doesn't mean that our life has to suffer, or that our days have to be painful. We do have the ability to have an impact on the quality of our days, so we can live our best life. And that's what managing chronic disease is for me, because we have these things. Once we have them, we have to figure out how to live with them. So I think one of the challenges is early on in a chronic disease, you may not have any symptoms at all, or you may have very mild symptoms of any one of these chronic diseases. Because of that, the first point I'd like to make is identification, right, or acceptance of the chronic disease is primary importance. So you don't know what you don't know. I have lots of people that say, this family member, my dad, I don't know, he never went to the doctor. So as far as I know, he was healthy, right? Dad could have had any number of chronic diseases, but if you don't identify them, you don't know until, something happens that may be drastic. So the first step, identifying or accepting a chronic disease requires some effort on the individual's part. It requires also trust in the system. So the effort is you have to seek out an evaluation. You have to go for routine screening. You have to have routine exams. You have to get your blood pressure checked. You have to have your blood sugar screened, maybe get your cholesterol checked. And then the next, important part, you do have to trust. You have to trust the ability of the system. You have to trust your healthcare providers to interpret the results that we may not understand. They're going to give you a bunch of information. And if they tell you the significance of this, we do have to put our trust into these systems. It's not always easy. It's not always easy to trust the person sitting across from you. They may be educated, they may have more time, but sometimes it takes a bit to develop that level of trust with your provider. But that is a big part of it too, identifying a problem and then accepting that it's true and that this is a chronic disease that I do need to manage. I think that's huge. Because if we skip that step, we're never going to get anywhere in managing any kind of chronic condition. So there's the identification piece that's necessary, but then accepting what information is given to you and trusting that that's true, so that you can then delve a little bit deeper. And I think the next step is educating yourself. So once you have been identified as having, say, diabetes, then what do you need to know about that? You have to feel comfortable that you can get your questions answered. Whether that's going to Star Hill Health Center or asking your primary care provider or your specialist, you do know those are the people that have the knowledge about the condition, and you want to seek out the right sources of information. So I please would urge people to beware of well-meaning family members or friends who have information about a chronic condition and might be wanting to share with you what they know about it or how they manage it or what they do. I think we should take those things with a grain of salt, but also be cautious about Facebook or online, advertising. I think there are so many sources of information these days, and we're constantly bombarded by information. Particularly, maybe you can get Prevagen to improve your memory. But you have to remember, and I almost every day have to tell people, Prevagen does absolutely nothing for your memory. There's never been any clinical trials that study this and look at good outcomes. But you're being bombarded by commercials, or you're seeing ads online that tell you, take this, it'll make you well, because that's what we want. We want to be well, so we want to believe that these people are telling us the truth. The reality is most of these supplements, the statements are not evaluated by the FDA because there's never been any clinical trials. And as long as they don't tell you they'll cure your diabetes, as long as they don't tell you they'll cure your heart disease, they can say whatever they want. So I do urge people to be cautious about your sources of information. If you do go online, sources like WebMD, for example, that's very reputable. You can believe what you see on that, but not everything you see online is true. Obviously, I think in this era, we probably all know that, but I still have people come every day to talk to me about how they read something, online, and they don't believe, that they should do XYZ because of what they saw online. So I do appreciate people telling me that, because that opens up a discussion. So if you do see something and you have questions about it, that's your opportunity to talk to your provider, about that issue. I think then the next step in chronic disease management is, of course, managing the disease, whether that's self-care, which is the treatment, the first line treatment, it should be the first line treatment, is the things that you can do yourself, the things that we can control for the most part, how we combat stress. And I try not to tell people to reduce their stress. I think it's the hardest and most weighty thing that we tell people to do. I mean, who can stop stress? Stress happens to us. It comes at us from everywhere. You can't stop it from happening. You can't keep stress out of your life, but you can find ways to try and reduce your body's reaction to stress. So whatever that is for you, whether that's deep breathing or meditation or getting a good walk or sleeping, those types of things to balance out and combat the stress. Those are huge in managing chronic disease. But the things that you will talk to your providers about, obviously, eating the right way for your chronic condition, your diet, the exercise piece is critical for most chronic conditions. But then the next step, of course, is medications. So I do want to spend a little bit of time talking about, and I hope that you all will ask if you have any questions specific to medicines and medication management, because I think some people are very cautious about taking medicine in general, cautious about the numbers of medications that they might have to take, which you should be. But one thing I will say is it's obviously important to continue your routine medications. But if you find that you're having trouble, if you find that you're having side effects with your medicines for your chronic problem, whatever it is, please, talk to the provider who wrote that prescription. Let them know. Don't wait until your 6-month follow-up to tell them you stopped the medicine. Please don't stop it on your own without letting them know. Chances are there's an alternative that you can take that can be changed easily if they know that you're having trouble. Or they can discuss with you ways to mitigate or decrease the side effects that you're having. Or if you just have concerns in general about not wanting to take the medicine or the cost of the medication, if you give them the opportunity to make adjustments, then your disease will have less of a chance to progress or get worse before your next visit. You could have had 6 months where you were being treated, but you may have stopped your medicine, and then by the time you see the doctor, you're that much behind the 8 ball. So that goes back to the trust of your provider and having communication with your provider. But I think that, and medicine isn't always the answer, but if you're taking medicines, it is important to communicate about how they're affecting you. And then another piece about medications to keep in mind is that some medicines you don't want to just stop abruptly on your own. They may need to be tapered off slowly. So it is also important for that reason to have communication with your doctor. And then the next point I would make about managing the chronic disease is follow-up. And that kind of comes to this 2020/2021 era as well. But, if you have identified that you have a chronic condition, you've accepted it, you've learned as much as you possibly can about it, and you're taking medications, but you don't go see the doctor, we won't know if the disease has progressed, or maybe, it's improved markedly, and maybe you can stop some of the therapies. But the follow-up is critical for chronic disease. These are things we're living with for our lives. Unfortunately, this is like I said, these are conditions that we are stuck with sometimes for years or decades. So follow-up is important, making sure that we're monitoring to see if the therapy is working or if you are having side effects. But also if you skip or miss your follow-up, that's another opportunity for things to progress to a point where you could have more severe disease, and that probably could have been avoided if you had regular appointments. And that, this year or the last year with the COVID-19 pandemic really has me worried about what people's health is going to look like moving forward in 2021. We are already seeing people delaying their routine care, delaying going in for follow-ups. They have justifiable fears. People have been told to stay home, right? We're all distancing, we're all staying in the house, and we're masking, and it is the people who have chronic conditions. Some of these chronic conditions, diabetes and hypertension and heart disease and chronic lung disease, these are the people who are highest risk for COVID-19, right? So understandably, there are fears about leaving the house. My fear is that we are concerned about possible risk of COVID-19, but we're not concerned about the real risk of progressive chronic disease. The real risk if you have hypertension and it's not managed, and you end up with heart failure as a result, and you had some symptoms that you ignore because you're scared to go to the doctor. There's a very real risk that you will end up sicker in 2021 because you didn't see your doctor for over a year out of concerns of potential risk for picking up the virus. We kind of have to frame it that way. And also, again, coming back to this trust, hospital systems, doctors' offices, hospitals are doing everything to keep people safe from the virus. Not only are they treating everybody with the virus, but people are required to mask. People are required to have screenings prior to coming in the building, whether it's temperature screenings, symptom screenings at the door. We are pre-registering at our office, so we have minimal people in the waiting room. Everyone is distanced. We're not allowing people to sit and mingle the way they used to. It's a very different world that we're practicing in right now. But this is because we know of the risk of the virus and we know how to mitigate that risk. And we're not allowing people in the office that have symptoms. So if you have a specialist, a cardiologist, a heart doctor, a diabetes specialist, or even just your primary care doctor, those are important appointments to keep too. They are very important appointments to keep now, because this is how we're managing our chronic disease to prevent us from getting sick in the future. There was a concerning report looking at deaths from March to May in 2020, and that was only just a portion of the year, and that was actually not the height of the virus. And we know now that we've had so many more cases of COVID-19 in the latter part, in the last quarter of 2020 than we did in the spring. But in that time period, when they eliminated all the COVID-19 related deaths, the number of deaths from any other condition were much higher than we had in the previous year. And we haven't been able to look at all that information for the whole year yet, but it is very concerning that more people are dying of other chronic diseases. More people are being diagnosed with breast cancers at advanced stage. There are other conditions people are developing that could have been picked up or could have been managed if they didn't avoid seeking care. So we have to seek care in a safe way, but that's another huge and important and salient point, I think, in this 2020, 2021 era. So I'm gonna stop here for a second. Again, I think it's a very broad topic, managing chronic disease, and I could talk for a long time, but I wonder if anybody has any specific questions, or if wants me to talk about any specific, chronic diseases or chronic, issues that they're encountering themselves. Or if the dog wants to talk, we could also have a chat. I could go get my dog too. Anybody?
Dr. Dennis, that was me. I was going to ask a question, but I'll wait till she stops barking.
Sure. I was thinking that was going to be me, that my dog was going to start making noise. So I'm glad it wasn't me, at least first. Anyway.
Must not
I see some familiar faces. I could call you out and ask when was the last time you went to the doctor. But I'm not going to do that.
So Dr. Dennis, I'd like to ask the question. I've heard that individuals who were on therapy for hypertension, if you will, because their numbers were doing well, they were able to get off of that medication. What is involved with that happening?
Yeah, so hypertension is a tricky one. There are many different factors that can lead people to have high blood pressure. Some of them could be more what we would think of as kind of genetic, just like how your body is made, how you have a certain balance of what we call adrenergic, or there's certain types of nerves that control our heart and our blood vessels and our nerves. And so if you have more balance of one than the other, some people have a tendency to high blood pressure, for example, or you have a little more of a certain hormone around your kidneys. So sometimes there are just intrinsic things in your body, just how your body's made, that lead you to have a tendency towards higher blood pressure. And so there's some factors that we can't kind of pinpoint all the time. So there's some things I can't put my finger on where we can see trends in families. For example, mom, dad, siblings, they all have high blood pressure, and then you come in and you develop high blood pressure. That's a little bit trickier situation. In that case, I don't typically give people the promise that they're going to be able to get off of their medicine for high blood pressure. There are people who clearly have a lifestyle-driven hypertension. They may be really eating too much sodium for their body. They could lose weight. They don't exercise. There are those people. I do see patients like that. Most of the time I tell them, if you make these changes and we see your blood pressure come down, great. We will decrease your medicine. And if we continue to see your blood pressure in a good range, we can decrease until, maybe you don't need it. The reality is many people are doing everything right and they still have hypertension. So I don't promise that I can get people off of medicine. But the other question I get though from folks is, well, my blood pressure is great. I'm taking my medicine every day. My blood pressure is good. I don't have hypertension anymore. Can I stop the medicine? No, your blood pressure is great because medicine is doing its job. Unfortunately, it's not like, taking an antibiotic and the infection is gone. The bacteria is dead. You can stop the antibiotic. The conditions that were leading you to have hypertension are often still there. And so you still require the medicine to keep that blood pressure good. There are certainly exceptions. There are definitely people who can really work on exercise, lose weight. They focus on their diet, low sodium, high potassium, high calcium diet. They're doing all the right things and their blood pressure goes down. And those people definitely can stop medicine in a controlled way with monitoring. That's not everybody though.
Thank you.
There is a question in the chat.
Okay.
It is, what's the role and impact of telemedicine in the management of chronic disease? How do we ensure equal access to telemedicine from the crowd?
Yes, so I have been tremendously grateful for the ability to use telemedicine and thankful that the insurers, Medicare is allowing us to reach out to patients in that way when we're trying to keep them at home. And I think moving forward, we'll continue to use telemedicine for appropriate conditions. It is an opportunity for, if we can use a video, this is a great opportunity for me to at least see a person to kind of assess, if they look like they're having trouble breathing, if they're in distress, we can do kind of minimal assessment. And as we're able to monitor people's blood sugars, people check their blood sugars on their own at home. So there's a real role for this telemedicine moving forward and just checking in with people and say, after we make a change to your medications, for example, let me check in with you in a couple of weeks and you can tell me what your blood sugars are running and we can make a change without you having to come in because maybe I wasn't going to do any blood work again either anyway. It doesn't replace the kind of assessment that we can do, obviously, when I examine you, or when we check your blood pressure, a manual blood pressure in the office. But it's been critical in getting some information and some data from patients and checking in with them and staying in contact with them during the pandemic. And again, I see a lot of use for it moving forward as well. But you're right, there is a challenge with people who don't have the same connectivity. So if you live in a place where you don't have access to the internet, if you don't have as much technological savvy where you can, set up a video visit, that is a challenge. Right now, I've still been able to do some phone visits with patients, which is very limited, but I can at least talk to you and get as much information as we can, and connect with people and make a decision about when you need to come in. And over the phone is really not ideal, but almost everyone has a phone, but not everyone has internet access. So I do see it as a similar kind of situation when we look at the schools and we look at students' access to education when we're doing virtual learning. It's the same kind of problem. There are going to be some people that don't have the same access. And so I think we're going to see still a divide. That's going to be an economic technology divide, which is, put in a little plug for the COVID vaccine. And I'm happy to talk about that too. But the more people who are at risk that we can get vaccinated, the sooner we can open up and have people come into the office in larger numbers, so we don't have that continued disparity between the people who have access to technology and the people who don't. Good question. Thanks.
That was just the one question so far on the chat.
Tiffany.
Yes.
Hi.
Hi, Raynell.
How are you?
I'm well. How are you?
Fine. Happy New Year to everybody. A question I had for you. A lot of us who are on Medicare, and you see the advertisement of you can talk to a nurse or a doctor 24/7 anytime.
Mm-hmm.
What have you learned, or what information can you share with us in terms of the reliability of calling a doctor or a nurse who's not your primary care provider for services?
Right. I think that having that access is important. I think that that's just another avenue for kind of getting plugged into some kind of care. It's not going to be ideal. I think insurers have a small piece of the picture when they look at your health overall. For example, there's a lot of insurers who are reaching out to people at home and asking them about doing colon cancer screenings or things like that, based on what they know, but they might not know everything your primary care doctor knows about, when you had a procedure, maybe before you were on that particular Medicare plan. So there's some limitations, but the reality is if this is a trained nurse, if they are often RNs, maybe you're talking about triage, or maybe the nurse coming out to your house to do some of the screening tests that they can do through a lot of these Medicare Advantage plans. I think any way that you can access care from a trained provider and get a little bit of information is helpful. The things that I kind of caution people about seeking out is like lifeline screenings, for example. Those things they send you in the mail, where you could pay to have, your bone density, your vascular screenings, your EKG, all this stuff. I would really be cautious about that, because some of the things that they do are not actually validated tests, and they actually do tests that are not indicated for everybody. We do things that have good clinical trials behind them. It's evidence-based, screenings that are necessary for everybody at different stages of their lives. But the lifeline is kind of like, if you think about living in Star Trek and they're just going to scan your whole body and like do a little bit of everything. It's not always necessary for everybody. And most of the time when people come in and tell me they did their lifeline screening and they bring the little paper in, and I say, well, this said it was positive, but you don't really have the symptoms. I don't really see it. But now that you have this thing, I can't leave it alone. So then I go and do the actual test to look for what they screen for. And it's most of the time it's not there. So I tell people most of the time, save your money, see your doctor, get the screenings they recommend when they recommend it, whatever's appropriate for you. But I think that utilizing the insurers, the Medicare providers, or even if it's a nurse triage line. If they
Mhm.
offer that, and you can call them with questions, with symptoms, I think that they are trained and you should use them
Okay, well, thank you.
in conjunction with your
Those
regular doctor.
lifelines are so expensive. I mean, the prices
They are.
are outrageous.
Yeah. I would save your money on that because they're trying to sell you something that, it's not, I would save your money.
Thank you. Appreciate it.
Anybody else? Well, since there is a little pause, I will put a plug in for the COVID-19 vaccine and ask maybe like a show of hands of the people who have their camera. Anybody planning on getting the COVID vaccine? Has anybody decided they're absolutely not going to get the COVID vaccine? Okay, so the rest of you are just thinking
I
about
have
it,
had it.
maybe?
No, just waiting to get the call when it's available for us.
Waiting for the call. Well, I like that.
Yes.
Yeah, I had mine. When did you have yours, Satur?
Last Tuesday.
Oh, we had it the same day.
Oh, really?
So how did
Congratulations.
you feel?
Good.
Tell everybody
I
how it
felt
went.
really good. The only little symptom I had, which I mean, I'm not even sure it came from the vaccine, but maybe I felt a little slight achiness in my legs that evening later.
Yes. I was hoping I would get a little sicker than I did, but I got, my arm as the day went on got more sore, and then that night I was like, gosh, even up in my neck is sore.
My neck,
And my legs,
my neck did
yeah,
feel a little tight, not much.
Yeah, and my legs were achy that night. And then the next day I was fine.
Yeah.
My arm was a little sore after that. I think, please ask if you have questions about the vaccine. I think it's very important that we have good information about it. And I can tell you everything I know about it. But I wanted to feel a little bit sick. I think that's the thing that people always tell me, well, I get the flu shot, I get the flu, or I get sick after I get the vaccine. Sometimes the achiness, the feeling feverish, the little queasiness, that's a sign your immune system is actually activated, your immune system is working. And so having that right after the vaccine is actually probably a good thing, because that means you're getting the response we want from the vaccine.
That's good to know.
That's not bad. That's good.
Yeah, that's good to know.
Yeah. So we'll be going back on the 19th to get our second one.
Yep.
And then hopefully, I think the last I heard, and maybe Camilla can help me, she might have better information, that the last I heard, I think by the end of January, maybe they're hoping to have most, if not all, of the healthcare professionals in the Centera system that want to have the vaccine done. And then should have some kind of plan as to how it will start to be distributed to the next stages, the next people.
That's good to hear.
But I've been telling my patients to look at the news, because it will be out there. Check with the health department. Wait, maybe don't bombard your doctor's office, but maybe wait till sometime early in February. And if you haven't heard anything and you're interested, call them then and say, do you all have a plan for the vaccine yet? Just kind of, like I said, maybe Camilla can tell us some more detail about that. But I think the plan is working. It's in work.
That
in
is
progress.
correct. Yes,
Yeah.
that is correct. Yeah, the plan is by the end of January to have our Centera healthcare professionals vaccinated. I do know that Centera Martha Jefferson is working with the health department and pushing the vaccine out to our community health workers. So more of our nursing home healthcare professionals, our EMS teams. So I do feel like we're starting to really make some movement with the vaccine. And like Dr. Dennis said, hopefully February we'll have a little bit more insight of how we can start rolling this out to our patients.
Have you heard anything about UVA? What's their schedule?
I have not heard anything about UVA.
Okay.
Yeah. Again,
My
I would
doctor
say.
yesterday, that's why I'm asking you. Yeah.
Yeah, I would say it's probably safe to even check with the health department website too, because once they start, they get the supply first, and then they distribute it to the systems, the healthcare systems, UVA and Centera. So they might have some information. I don't know if they will be directly distributing, to patients any of the vaccine, but that might be another place to look for information.
They've already started. My daughter had the test done on Monday.
The test, or she had the vaccine?
I mean, the vaccine, I'm sorry, the vaccine.
Through the health department?
Yeah. No, through UVA.
Oh.
Yeah.
So your daughter is, does she work for UVA?
Yeah, she works for UVA.
Right.
Inpatient pharmacy.
Yeah, I think the question was about just general patients getting the vaccine through UVA. So I would,
Well, Dr. Dennis, I think it's and thank you all for having this, because I'm seeing a number of women of color speaking about their health, which is so important, and you're speaking to the vaccine. And we know that there's within the Black community some hesitancy to get the virus, and legitimate reasons. But can you speak to how you all are trying to penetrate the Black community to, squell or allay some of those fears and concerns?
Yeah, maybe Sator can speak to that, because I believe that there are some efforts underway to have some public service announcements, put out into the community so people have more information about it. I think you're absolutely right. We have all this historic mistrust of the system, healthcare systems in general. But there's also, outside of the Black community, there's just general kind of concern and mistrust about this vaccine. I hear a lot of people with concerns about how quickly they believe it was developed, or they read online that there are going to be microchips, inserted into your body and the government's going to track you. I mean, there's a gamut of concerns about it. And that's why I said, please, please, please ask if you have questions. There's no question that is silly or doesn't make any sense, because I think that the more information you have from reputable sources, the better. And it doesn't mean that everybody's going to feel comfortable with it, but the reality is we are disproportionately affected for whatever reason. And the disparities in healthcare between Black people and white people in this country have just been magnified by this virus. And if we are avoiding the vaccine, we are going to continue to suffer. And if we think about the economic impact on our communities, that's not going to improve either if we can't become immune to this. So yes, getting the information out is critical. Having people understand the science behind it, and know that this is not new. This is not new technology. They didn't just go sit in a lab and say, oh, it's 2020. We need to figure out a way to make a vaccine to this brand new virus. That's not what happened. The technology being used for this virus has been around for a long time. And all they did was take the little piece of the outside of this virus and use it with the science that we already have to make this virus. And the reason that it happened so quickly is because there had been an effort on a global scale to put finances and manpower on this vaccine in a way that has never been done. I know people personally who work for companies like AstraZeneca, who make regular vaccines that we have in our doctor's office every day. They shut down those divisions entirely and put all of those people on this vaccine. The drug companies didn't have the kind of incentive to work on other vaccines in the past to take longer because they had fewer people working on it, less money to put into it. That's not the case with this. We have massive amounts of efforts put into this. And that also, I think, informed how many people were willing to sign up to volunteer for the trials. So we have tens and 20 and thousands of people who were in these trials to study the vaccine, who got the vaccinations for the study. So we have enough number of people who got these drugs, who got the vaccines, who had been shown to tolerate it, who were safe in the trials for months and did not have significant adverse effects and showed that they developed immunity. We got to those numbers that we need to show the vaccine is effective in a time frame that is unprecedented, because there were much more effort to do that versus, you know, if we have a vaccine we're developing over years, but it takes us so long to get enough people to take this vaccine to get to those numbers. Well, we had, you know, influx of people that are going to volunteer, numbers that you don't see typically. So this was all accelerated because it was necessary, but it wasn't because they skipped steps, if that makes sense.
It does. And I think that's why it's important having someone like you share this information. About you, I mean, you're an African-American female doctor. And it's always been important to me to have someone that looks like me that can be that you know, you can get this information from. Not that I don't trust other doctors. I've had white doctors before, but having you all here speaking to us, particularly women of color, is so important.
Yeah, understood.
Yeah.
Any other questions about the COVID vaccine or anything? Ms. Joyce? I think you're still muted.
I'm gonna just pop on before Joyce says something while she figures out her her sound. But to answer the question that you talked about was targeting the Black community, specifically on making sure that the education and getting the vaccine out is really important. And actually, the coalition that Centara Martha Jefferson is a part of, the Move to Health Coalition, currently has a group. One of their groups is working on specifically that project. So we should be able to see the results of that very soon, hopefully. So yeah, there are people working on it. And if you want to get involved, just let you can let me or Sator know, or Tiffany, and then Dr. Dennis can send you our way. Thanks.
Can you put that info in the chat? Because I work for the Chamber of Commerce, and we're already getting questions on where individuals can get this information, and I'd be more than happy to forward that along to them.
Yeah, for sure, I will.
Okay, thank you.
You're welcome.
Yeah, I just got notification about the public service announcements where they were asking some of us to be involved with that. So it's in the beginning stages, but it will be coming. Someone had just sent me an email about that today. So there will be more that will be coming. There will be public service announcements coming out soon.
Sator, did you also see all that information? There was like that poster and the myths about the vaccine. I think it was emailed out today to the system. I can send it to you if you don't, but sharing it with at least your cohort.
Yeah, send it to me. I'm not
patients.
sure if I got it or not. I may have, but that would be helpful. Yeah.
Yeah, I'm
That
not
was
sure
a
who that
great
went to.
resource. Yeah, it was a great resource. It also has fact pages about the vaccine. So not just myth busters, but also facts about how the vaccine was developed and distributed. So I think that would really help as well.
Right. I've been talking it up with folks, you know, just family and friends saying I got the vaccine. And it was kind of funny. I was talking with my some family last night, and then they had lots of questions about it. But I think as people start to get vaccinated and we see how it affects or doesn't affect, you know, and we can spread the word, you know, about it, that will definitely hopefully be a positive.
Yeah, I think even just having these few weeks, you know, before it's generally available to the public, where people can ask, you know, their provider, did you get the vaccine? You know, how are you doing? And they can see that there are numbers of people in the community that had it and that they're doing well, may encourage more people to seek out the vaccine. Ms. Joyce, you had a question?
Yes, I did. Question, comment. I've had people, and I've heard people question why this vaccine was developed so quickly, and yet we can't get the flu vaccine straight. And my answer to them is, we had a specific germ, if you will, a specific virus that they were developing, whereas the flu, you're guessing from year to year what that flu is going to be, and that's how they make up the vaccines. So you're actually not comparing the development of the same things.
Absolutely.
And I'm just
Yeah.
saying that's correct. That's already been identified.
So,
And
yeah.
each year with the flu, you're
Yeah, you're right. So the thing about these viruses is they're all a little bit different in how they act and how they mutate, right? And how they change. And the flu has what we call drift, significant variations in the virus throughout the year. So very rapid changes in the flu virus. So when they do try and you know, it's not just developing the vaccine, right? We have the technology, we know how to make the vaccine, but we have to target it towards the specific virus that's floating around. And if you predict at one part of the year, this is what we're going to be seeing, you know, 10 months later, sometimes you get it a little off. We don't get it exactly right because you do have to make it. You know, once you predict what we want, then you have to replicate it in the factories, right? They have to make it. And that is what usually takes so long to keep doing and distributing. But all these efforts have been made into not only developing the vaccine, but making it just and then producing it and distributing it very quickly with this vaccine. And it is different. I was telling somebody today, think about it like measles. We have not changed the measles vaccine. People still get the same measles vaccine that they did when I was a kid. The measles virus is different than the flu virus. We don't have to have a new measles virus every year. The measles has not gone away. Clearly, we have seen people who are not vaccinating their children, and we have these little outbreaks, right, of measles. Virus is still here. You're not seeing the number of people with measles being admitted with meningitis and severe cases of the disease, but it's still here. And my prediction is the coronavirus, this SARS-CoV, this particular coronavirus, because there are lots of different coronaviruses, right? This is just one particular type of coronavirus. This particular coronavirus is not going anywhere either. And we have a vaccine. Granted, we don't know if this vaccine is going to have long-lasting benefits. We don't know if this is going to be, you get this vaccine and you'll never, ever need one again, right? We don't know that yet. This is all very new in its infancy. But if we think about something between the measles vaccine, the measles virus and the flu virus, the coronavirus is somewhere in the middle there. It's not able to mutate and change so drastically as a flu is. So that's very true. You have heard of these newer strains that they're seeing in South Africa and the UK and other places in the world, and now some of the states in the United States have identified these strains. But the piece of the virus that we're using, the important part of the virus, the spike that's being used for the vaccine, that's a part on the outside of the virus that is necessary for the virus to get into your cells. That's how the virus gets in and sets up shop, for lack of a better word, and multiplies. That little piece called the spike, that is not changed on these newer strains. So they believe the vaccine is going to be as effective. It is the same piece that they use to make the vaccine that we are pushing out now. So that part of it, the virus hasn't changed so much that the outside of these new strains is different. Hi, Ms. Shields.
Hi, how are you, Dr. Dennis?
I'm well. How are you?
I am fine. I just got another steroid shot and my back is getting better all the time.
I saw that. Well, I wish I were wherever you are. That looks nice.
Well, I'm not really there.
I know.
just play around in the background. It's the island of Iona.
I know.
I just sent the link to my brother too. We'll see if he joins.
Well, we're just going through some questions. So if anybody has any other questions, like it doesn't have to be about COVID. You probably are tired of hearing about the vaccine and the disease itself. Any questions about any chronic problems that you or a family member might be dealing with or struggling with, or any resources they could get, please don't hesitate to ask. This is the time.
I'm sorry to have so many questions.
No, I appreciate it.
Colonoscopies. I've gotten something again in the mail about getting them now that the age has been lowered, and then you hear about these individuals who are in their 40s dying of colon cancer. And can you just speak to that, because I'm 48, so,
Right.
and the new information I'm getting is saying 45 when it used to be 50. A little confused.
Yes. So the thing about that really blows my mind is that that's not new information, unfortunately. From, when I was in medical school, it was always, well, if you're African American, you should consider getting colonoscopy starting at 45, because colon cancer may develop earlier, it may be fatal earlier in this group. But the problem is insurance companies have never covered a screening colonoscopy for somebody at age 45 without a family history. So if you have a family member who has colon cancer and they are diagnosed at age 55, then you, if it's your parent or a brother or sister, so a first degree relative that has colon cancer diagnosed at age 55, then you can get a colonoscopy for screening at age 45, and your insurance company will cover that, because we want to give you that lead time. We want to start screening you earlier than your family member did, because colon cancer, to back it up a little bit and kind of explain the whole process, is, colon cancer takes a long time to develop. It's pretty systematic. It's pretty predictable, from a small polyp to a larger polyp to different, higher grade polyps until it becomes colon cancer. That takes a long time. For most people, it is over years and almost a decade before it develops from a polyp with a risk for cancer to a cancer. So the screening can be, over years. You can wait years, but if you have a family member that was diagnosed at 55, that means if they had had a colonoscopy, say at 48, we would have seen a polyp maybe that was going to develop into that colon cancer, right? So if we know that your family member had it early, then we want to screen you even earlier, so that if we see something, we can take care of it right away. And then you continue to have the routine screenings based on, what they find on your colonoscopy. Problem is, now there's more of a push and there's more of a recognition and the discussion about screening early for African-American patients at age 45. I have not yet had an insurance company that was paying for a screening colonoscopy at 45. If you are considering doing a colonoscopy before age 50 for screening, you don't have a problem, you're not having bleeding, you're not having symptoms where your doctor said we need to do this colonoscopy for diagnosis. If it's purely for screening and you're not 50, I would really encourage you to make sure that there's a discussion with the endoscopist, the GI, gastroenterologist beforehand, because it's a very expensive procedure. Ideally, in the ideal world, it should be covered by your insurance at 45. But you want to make sure that it is, and it's covered as screening, so you don't end up with a bill for thousands of dollars. Sorry, that was a very long answer, but
That's interesting. Does polyps lead to colon cancer?
Sorry, what's that?
Does polyps lead to colon cancer?
They do. There are some very benign polyps. They're just like little bumps, look like little tiny little mushrooms in there, like they're called hyperplastic polyps. They will never turn into cancer. But there are some polyps like adenoma polyps or flat polyps we call sessile adenomas or serrated adenomas. These different types of polyps have different risk. Some of them are higher risk for colon cancer and other ones are lower risk. So that's where you might find that if you go, somebody has a polyp and they get told they can come back in 10 years for a colonoscopy, but you have a polyp and they say come back in 3 years, or they say 5 years. And it depends on the type of polyp, how big it is, when they want you to come back. It depends on, so it all has to do with the potential risk for that particular polyp. I mean, I think colonoscopies are huge because, you can do those mail-in tests, right? Even your insurance company, Medicare, might send you the little thing, oh, you can just do this every 3 years. I really don't recommend the 3-year test. I can explain that if you want to know, but you can do a screening test with just your stool once a year instead. If you've never had an abnormal colonoscopy, at least it's something to screen. But a colonoscopy is a screening test, right? It's looking to see, is there any polyp there? Is there any risk for colon cancer? It's also diagnosis. So if they see something there, they can take it out and they do the pathology. They look at it in the lab and tell you what it was. and is this cancer? Is this a high risk polyp? They give you a diagnosis. If it was cancer, you're cured because they took it out early. So the colonoscopy is screening, diagnosis, and cure potentially. If there's nothing on your colonoscopy, then it's just screening, right? And that's where you get that screening colonoscopy. If they don't find anything, they say come back in 10 years. If you do one of those stool tests that's once a year, that's a screening. If it's negative, that means you're low risk to have a polyp or a cancer. You got to do it again next year and the year after that and the year after, just to be as good as a colonoscopy at screening. But if it's positive, then there's a risk that you've got a polyp in there or a cancer. You got to get a colonoscopy anyway. And at that point, we're at the step of diagnosis. So that's a diagnostic colonoscopy because we know there's something there. We know to get rid of it.
Does insurance cover the at-home testing or screening?
So insurance does cover that, yes. The test, there are two tests. There's a FIT test, which is a very specific DNA test that looks for high-risk polyps and colon cancer. It's a stool test. You just test one bowel movement, and then you return it to your doctor, and then they test it in the lab. That's once a year. There's another test that you've probably seen commercials for. That's the Cologuard. I don't like that test, and most of the gastroenterologists don't like that test for two reasons. It's very expensive because it's proprietary. So the company has combined the FIT test, which is the one that I like, that's the once a year test, with another test. And that test is not very specific for colon cancer. That other test that they do can come up positive a lot of times, and there's actually no cancer. I've had many people that have that test and they end up with a false positive and they go get a colonoscopy and there's nothing there. And the problem with doing that test is they do both of those tests with the Cologuard. And when they send the results back to me, they don't tell me which one was positive. If they just told me the FIT test was positive, I could know and say that person needs a colonoscopy, but they don't tell us that. And that's the company's prerogative. They don't give you that information. So I don't really like that because I've seen more people that have a false positive and then they end up getting a colonoscopy that they have to pay for and there was nothing there. But there's two at-home tests you can do, the FIT test once a year and the Cologuard every 3 years.
May I ask a question?
Please.
Is there any symptoms for having colon cancer before you do the test? Is it anything you can judge?
That's the short answer is no, hopefully. I like to think and I tell people, by the time you have symptoms of colon cancer, that's not a good thing. That's probably too late. If you have something that's small and it's still a polyp or it's a very small cancer, you may not have any symptoms at all. Most people are not going to have any symptoms at all. If you've got a cancer that's in a particular spot, it can cause some symptoms. You can have abdominal pain. You can have bloating. You can have change in your bowel movements. So maybe your stools become really narrow. They're very small all the time, like pencil thin. That can happen sometimes with people with colon cancer. But oftentimes people have a colon cancer that they don't have any symptoms and then until maybe it's spread to their liver or something like that, or it's spread to the lining of the abdomen. And that's really not when we want to diagnose colon cancer.
Okay, thank you.
You're welcome. Any other questions or thoughts, comments?
Nobody else? Well, we're getting close to 6 o'clock, so,
I have a question.
okay.
Yes, Ms. Fleming.
How are you, Dr. Dennis? If you're allergic or to penicillin or something like that, have allergies, does this affect the shot for the virus, cold virus?
Oh, yeah, that's a great question. I think I've seen or heard somewhere on the news or something, if you have allergies, talk to your doctor about it. And I think, just having an allergy to penicillin, for example, does not mean you can't get the vaccine. Where I'm cautioning people, and of course, before I say anything, I would say you should have a discussion with your doctor about it individually if you have questions about it. But generally speaking, what I am telling people is if you have had anaphylaxis, meaning you have shock, your body had shut down, you need an EpiPen, you had a severe reaction to other vaccines, you might be somebody we want to hold off on, right? I would not recommend going for the COVID vaccine at this point if you've had anaphylaxis from other vaccinations, because I would like to see more people get it and recognize who might have that kind of reaction before I recommend it for my patient. If you have an allergy to peanuts or you have an allergy to penicillin, I do not believe that's going to be a contraindication for you getting the COVID vaccine. But again, I would just urge everybody to talk to your doctor individually if you have questions about should I get it, am I at risk for an allergy or an allergic reaction?
Thank you.
But you can get it.
All right.
Well, thank you so much, Tiffany, for doing this talk. It's been very informative and enjoyable. So I really appreciate you doing it. Hopefully we can have you back at a later time for some other not as broad topic.
Well, I'm happy to do it. I really appreciate it.
Yeah. Just a reminder to the ladies on that are part of our group, we will be doing fresh pharmacy pickup tomorrow. So that's just to remind you all not to forget your fresh vegetables. If there are no other questions or comments, then we will end this Zoom session. And everybody have a great evening and a blessed rest of this week, and be safe.
you.
Thank
But
you.
thank you, Dr.
Thank
Dennis.
you. Thank you all. Good night.
Welcome.
Bye.
Bye-bye.